Good morning, everyone. It's great to be here. I'm a practicing physician. I teach and see patients at the National Institutes of Health and the Walter Reed National Military Medical Center in Bethesda. Full disclosure, I'm a reproductive endocrinologist, so when we talk about end of life, I'm on the other end of the spectrum. I put sperm and egg together at the beginning of life. So, but from a personal standpoint, I can also tell you that I was a GYN oncology. I almost became a GYN oncologist before I went into reproductive endocrinology. So I was one of the people that did a lot of those last week surgeries that Dr. Gawande talked about. And I lost both my sister, my younger sister, and my father to metastatic cancer in 2008. So I'm very familiar with some of the issues that we're talking about here. But I appreciate the opportunity to speak on behalf of the American Medical Association and our 250,000 physician members as the largest physician organization, and talking about these very critical issues that we're discussing here today. And our organization has had a long history of establishing policy and ethical guidelines about care, not just end-of-life care, but about care in general. And so it's great to be able to talk a little bit about what we're doing in this area, and we appreciate this important report by the Institute of Medicine and how we can augment that. And I was asked to specifically talk about communication and advanced care planning. And communication to me in this area comes down to three major focus areas, which is communication with patients, communication with other physicians and caregivers, and communication with regulators and legislators. And so I'll talk a little bit about each one of those as we go forward, but I wanted to talk about how the IOM's recommendations on improving end-of-life care match up very well with a number of the policies and ethical things that we've discussed at the American Medical Association. In helping families deal with illness, physicians and all caregivers are always in communication with them, and we cherish our relationship as physicians with our patients. We're there with a large portfolio of things we can use to help our patients. Surgery, medications, diagnostic tests, all of those are part of that. But also we're there as someone who can supply comfort. And I think that's something we have to remember, that it's not just about surgery and medications. It's also about providing comfort to the patients that we have that are suffering. And so as part of that, and in an environment where very hard emotional choices have to be made, we think that communicating with patients about these issues and discussing them with them and helping them work on a plan is an essential part of our tool set that we have to use in caring for our patients. So advanced care planning can help this process be a little easier to actually document the patient's wishes, and we've strongly supported the end-of-life planning and the use of directives to do just that. And we want to make sure that we have something there that can give both physicians and other caregivers and their families direction about what the patient's wishes are at a time that they might not be able to speak on behalf of themselves. And so starting the patient conversation long before they're seriously or terminally ill is important. And so that we promote the fact that patients need to take an active role in their own health and think hard about the questions separate from when the heat of the moment is occurring, as we've all heard today. And this is part of the trust and empathy that we establish with our patients in that doctor-patient relationship. Now, these are hard conversations to have, and it isn't something that naturally comes to anybody, and so it does require, I think, some formal training and education. And so, we think that it's important that all physicians be taught that, not just specifically about end-of-life care, but anytime you're talking with a patient, there are communication skills that are critical to being effective in providing care for your patients, and so we want to incorporate it in that. So, we have supported the need for physicians to have better training about communication, whether about end-of-life discussions or any other care discussions as well. We've also developed some resources that we think can help this, and specifically one was called the Education for Physicians on End-of-Life Care. And we established this in collaboration with the project at Northwestern University Feinberg School of Medicine. And we have links on our website and other resources along with this, but this was an active project that we put in place specifically to talk about educational needs in advanced care planning conversation with patients. And so I'd recommend taking a look at our website. We have resources for both patients and physicians and other caregivers. And we participate in the annual National Healthcare Decisions Day held on April 16th to encourage people to have conversations about end of life with their families and loved ones and their caregivers. And so moving to the other group that I think needs to be communicated with, these end-of-life discussions and all care discussions, they take time, they take preparation, and we believe that they need to be covered as part of the care process that we're reimbursed for. And so, thank you. So Medicare and other payers need to recognize the time that goes into this and the importance of it as well. So codes, which is the way we communicate with payers, that would allow a payment for advanced care planning, have been developed and recommended to places like the Centers for Medicare and Medicaid. But at this point, CMS has not chosen to adopt them. So we would be continuing to advocate that these codes be adopted and paid for, not just by the federal government, but also by all payers. So, we've already heard a lot about the problem that we've seen with death panels and all of that. We don't think, though, that we want to get to the point where you have to read off a script and check off a box to get paid for end-of-life care. That's not what we're seeking at all. In fact, we are very concerned about the risk of it turning into that. So with that, I would just say that we also have put together the Consortium for Practice and Performance Improvement, along with an NCQA, where we've developed a set of measures that individual physicians can use on palliative and end of care. These were adopted back in 2008, and so this is our chance as physicians to write guidelines for physicians by physicians. And then finally, we just want to say that a key component of palliative medicine is that physicians have the ability, without being concerned about excessive regulatory scrutiny or criminal prosecution or inappropriate disciplinary action, to effectively and appropriately prescribe and administer controlled substances that treat intractable pain for patients. And we recognize there's a big problem with prescription drug abuse, particularly with pain medicines, but we also don't want the focus on that problem overshadow the great need and great benefit that we can derive from medications that alleviate pain. I just want to finish up by saying that, I served a little over 23 years on active duty in the Navy, and one thing that I learned in the Navy is never underestimate the power of unity of effort. And so I'm really proud to be part of this panel in this day on this unity of effort in this very important area. So I really appreciate this opportunity to share with you our concerns as physicians, but I really also appreciate the opportunity to be part of this unity of effort. So thank you very much.